So the first case, so actually we're going to do two cases discussing pros and cons on targeted therapy and PRRT. So the first case is a female patient, 42 years old, my age, ECOG 0, no comorbid illness. In April 2015, she presented abdominal pain that ended up being diagnosed with gallbladder stones, went for a cholecystectomy, and then during this operation, there was an intraoperative finding of an infiltrative lesion in the liver. That was biopsy at the time, which came as a well-differentiated NET with a mitotic index of 1 and Ki-67 less than 2%, with immunohistochemistry differentiation for neuroendocrine. Because of that, she underwent a sequential enterectomy, so they found the primary tumor in the ileum. And that came as a PT3 and 1 out of 5 lymph nodes resected and 1 in the liver. She did not have any complaints about symptoms at the time except for the abdominal pain, but I don't know why, maybe just recall bias. 1 month about approximately later, she started having the symptoms of diarrhea and cutaneous flushing. And then her 5-HAA was measured in the 24 hours urine and came elevated with 50 milligrams. So she was then started on treatment with octreotide LAR 30 milligrams. She improved her symptoms, but after 10 months, she developed symptomatic and biochemical progression without radiological progression. So at that time, she had a PET gallium-68, and as you can see here, is highly positive, the scanning in the liver. So with that, Ramon, what would you do?
Yes, thank you. So my summary of the case, this is a very young lady, PS0, so no problems there, no problems in comorbidities. It's a mid-gut primary, G1, well differentiated, and it's clearly unresectable, widespread liver metastasis, liver dominant, actually liver-only disease. Tumor burden is high, and it's a clear functional syndrome from the carcinoid, and also progressing in the functional syndrome, but not in radiological imaging, so a stable growth rate. And SSTR expression is allegedly high because we've seen the gallium PET. So, and she has been receiving 30 milligram sandostatin LAR, so previous treatment somatostatin analogs. The question here is, what is the goal of therapy? Very low grade, 1%, 1 mitotic index, and less than 2% Ki-67. For me, the clear answer here for the goal of therapy in this moment, without tumor growth progression, is just symptom control. And I am a very obedient INETS, European Neurocrine Tumor Society member, so I go with what the guidelines say in this case. And the guidelines just say to consider, in this case, the bulking surgery. I don't have the bulking surgery of liver metastasis, or locoregional ablative therapy, or somatostatin dose increase, or add-on interferon, and as you know, alternative third or fourth options, pasireotide or a clinical trial, or PRRT. And as an alternative option that came up 2 years ago in results of a clinical trial, telotristat, which is not yet available because it's not yet accepted. But this is what our guidelines say on this case. If you are very eager to individualize tumor progression rate at the first hint of tumor progression, I would consider everolimus. I am here to defend targeted therapy before PRRT because of the RADIANT-2 trial, which was a negative trial, I have to say, but just by hitting the bar, because p-value was just 0.026. And then the Radiant-4 confirmed the value of everolimus in these patients with non-functioning, but for tumor growth only. But again, I just want to say that in this patient, I believe the goal of therapy is symptom control.
So, reiterate, we're talking about symptomatic progression of carcinoid syndrome in the patient with midgut net and liver-dominant disease. And while we can debate what the right treatment is, I think Ramona and I perhaps agree that the wrong choice here is everolimus. And why do I say that? Well, as Ramona indicated, the most relevant study is the phase 3 Radiant-2 study. It evaluated patients with neuroendocrine tumors and carcinoid syndrome, as this patient has. Unlike this patient, they all had radiographic progression at baseline, and they were randomized to everolimus plus octreotide versus placebo plus octreotide, with the primary endpoint being progression-free survival. This was a negative study. The study did not meet its primary endpoint. The p-value fell short of statistical significance. Perhaps even more concerning than the failure to establish improvement in progression-free survival was the overall survival curves, which, as you can see here, show no trend whatsoever towards improvement in overall survival, and a hazard ratio that's actually greater than 1, raising the concern that perhaps the modest, benefits in PFS are outweighed by increased risk and perhaps even deaths as a result of toxicity. Now, why was this a negative trial? There's many possible explanations, one of which I think very convincing being that patients enrolled had very slow-growing disease. And when you have very slow-growing disease, the opportunity to show benefit is relatively low. Well, if the drug is inactive in patients with slow-growing disease, I think it's very inappropriate to administer it to a patient who has no radiographic progression whatsoever. Not only that, but we also don't have any evidence that everolimus actually improves symptoms in patients with carcinoid syndrome refractory to somatostatin analogs. And in fact, one of its major side effects is diarrhea. So if you have a patient with refractory diarrhea, you add everolimus to the mixture, you're very likely to have a patient who has worse diarrhea. And we can see here that the rate of all-grade diarrhea nearly doubled on the Radiant-2 trial. And there was near tripling of the rate of grade 3-4 diarrhea. So everolimus would definitely not be my choice in this case. What about peptide receptor radiotherapy, radiolabeled somatostatin analog? Well, we actually have a trial that addresses this particular scenario. This was a phase 2 multicenter trial looking at yttrium-98 octreotide in patients with refractory carcinoid syndrome. They received 4 doses of the drug. Primary endpoint was improvement in symptoms, and in fact, the trial did show durable response in terms of flushing and diarrhea in 51% and 60% of patients, respectively. We also more recently have the NETTER-1 study, which is a study that evaluated lutetium dotatate versus high-dose octreotide in patients with midgut neuroendocrine tumors progressing on standard dose of octreotide LAR. And this study, as many of you know, showed a very substantial improvement in progression-free survival, both clinically significant and statistically significant. More pertinent to this case, it also showed improvement in symptoms. Patients filled out EORTC quality of life questionnaires every 3 months. In terms of global health status, it improved on average on 28% of patients versus 15% of patients in high-dose octreotide. It worsened in fewer patients on lutetium. Similar picture with diarrhea, more improvement and less worsening with lutetium. And as far as flushing, we see more levels of improvement compared to decline in both arms of the study, both lutetium and high-dose octreotide. So there's certainly evidence that peptide receptor radiotherapy not only delays progression-free survival, but also can improve symptoms in patients with refractory carcinoid syndrome. I think it's also important to acknowledge that these are not the only 2 options. And in fact, an option that should be strongly considered in a patient like this was liver-dominant metastases, non-radiographically progressive, but clinically progressive, is hepatic arterial embolization. And while we don't have any real good randomized high-quality clinical trials, we have decades of institutional retrospective experience and some small phase 2 studies showing that roughly half of patients experience radiographic response. And more pertinent to this case, roughly 75 to 80% of patients experience symptomatic response as well as improvement in biomarkers. And I can say from experience in a case like this, if we perform hepatic artery embolization, we'll see symptomatic response in nearly all cases. I want to alert you to the recent publication of the North American Neuroendocrine Tumor Guidelines for midgut neuroendocrine tumors, which looked at a variety of scenarios, including this exact scenario. And in this scenario of symptomatic progression but not radiographic progression, liver embolization was considered the appropriate choice. In cases of radiographic progression, PRRT was considered more appropriate. And finally, as Ramon has already mentioned, there is a new drug, telotrestat, a serotonin inhibitor that's specifically indicated for patients with refractory diarrhea related to carcinoid syndrome. It's available in the United States, likely to be soon available in Europe as well. Thanks.
So none of you considered escalating the dose of the octreotide?
It was one of the options after local-regional therapy. We actually agreed on the local-regional therapy, although we had to defend different options. But yes, it is one of the second alternatives in the INET's guideline.
Right. There's virtually no prospective data on that. We've published several retrospective series, and there does seem to be some benefit. It's hard to quantify. It seems to be mostly in patients who have exacerbation of symptoms towards the end of each cycle of their somatostatin analog. If you administer it more frequently, most of the times those symptoms improve. If the symptoms are worse throughout the entire, 4-week cycle, there may be some benefit, but it's not going to be usually as dramatic as you get with, hepatic arterial embolization, for example.
And do you consider the PFS arm of the NATO one, which is about 8 months or so, controlling, as one of the prospective data? It's not for symptom control, but it's certainly for disease control.
Right. It's hard to know what that 8 months mean. Is that long? Is that short? These were patients who had an average or median PFS or median interval between their pre-trial scan and baseline scan, which was required to prove progression, of roughly 11 months. So it's really unclear whether the escalation in octreotide changed the dynamics of that progression.
Yeah, I have a question on the access to PRRT. What is the waiting time for patients, even in a referral center where you do PRRT? Do you have an idea of the waiting time? Because you may have several months of, I don't know, what's your experience with that field?
Here in Europe, there are 10 countries where a compassionate use program is active. We need to acknowledge the fact that it is not yet an approved registered treatment from the agencies. But of course, we prioritize these cases with syndromic control need, and it's not a question of waiting time for those centers that have this program active. A question is of availability of the treatment worldwide.
Yeah, it's the same in the US. We have early access programs available.
Well, in Brazil, you can get in the next week, but you have to pay. So case number 2, a male 67-year-old ECOG1 with well-controlled arterial hypertension, ex-smoker, and with a history of mild chronic obstructive pulmonary disease. This man was asymptomatic until September 2016, when he did an ultrasound just as a checkup, and liver nodules were identified. Then a biopsy was undertaken that showed a well-differentiated NET with a Ki-67 of 15% and 5 out of 10 mitotic index, with chromogranin and synaptophysin immunohistochemistry expression positive. On imaging, regular conventional CT scans, there was a thickening of the ileum wall suggestive of a primary tumor, but he had no symptoms associated with this primary tumor. And the 5-HIA was normal in the urine. He then was started on lanreotide, 120 milligrams subcutaneously. From February to July, when there was radiological progression, approximately a 10% increase in tumor volume. So this is the summary of the case. This is not the CT scan, sorry, the MRI showing multiple liver lesions, so not operable. And the octreal scan was positive also in the lung. So in this case, would you change your mind, Ramon?
This is a completely different scenario. So here we have another mid-gut patient with intermediate high. Ki67 is 15%, closer to G3 than G1. It's between 2 and 20%. And well differentiated, and again unresectable, clearly unresectable if you look carefully in the MRI, and liver dominant and bilateral, and I would say high burden of disease in the liver, and non-functional. It's slightly progressing, growth rate 10%. It does not qualify for a resist progression, but in terms of neuroendocrine tumor evaluation, these patients were included in the pivotal trial for progression of disease at baseline. And again, octreoscan is positive and is receiving prior treatment with a standard dose of somatostatin analog as anti-proliferative. So what to do next? It's quite easy. We just have two phase 3 medical treatment clinical trials. Here I would favor first medical treatment than local regional. It's non-functional and it is really bulky disease, so it could be dangerous to apply local regional treatment. And we have the Radiant 4 with these curves. I want to be fair, and hazard ratio for this is 0.48. Progressing patients like the case number 2 we have here, and the Netter 1 hazard ratio 0.2. Two independent trials, two different trials, quite similar population and similar results, but I would not dwell into the magnitude of the hazard ratios because I need to defend everolimus. So I will go on to discuss a little bit a couple of studies, a big 169 patient study from Italy looking at toxicity of everolimus before or after PRRT. And the authors saw clear trend that was statistically significant in favor of higher toxicity of everolimus following PRRT. So it seems it's safer to treat everolimus before PRRT. On the other hand, there is a small Dutch retrospective study of 24 patients that does not confirm this trend, and there is no info on patterns of toxicity of PRRT before or after everolimus. But in my humble opinion, the later you provide PRRT, the smaller the chance to have long-term myelotoxicity of radionuclides. So what does the INETS guideline recommend in this scenario? Everolimus is limited when uncontrolled diabetes or lung disease. This patient had some obstructive lung disease, but it was mild. I don't think it counterindicates everolimus. And PRRT limited by extensive hepatic disease. This is what the guidelines write, and we will discuss it later. And here the patient had extensive hepatic disease. And the last argument in favor of everolimus is the widespread availability of everolimus. if you live in a country that can pay for it, or you can pay for it. But PRRT is not yet approved and may not be widely available. So this is my case.
All right, so to reiterate, we're talking about a patient with probable midgut net, strong somatostatin receptor expression, and this time radiographic progression. So I'll acknowledge, based on RADIANT-4 trial, that everolimus is a legitimate option in this case, but let me make what I think is a stronger case for PRRT. Again, reiterating the major PFS benefit on the NETTER-1 trial. The fact that objective responses were seen in 18% of cases with lutetium dotatate versus less than 10% that has been seen on the RADIANT trials. And the fact that on preliminary analysis of overall survival, there were nearly twice as many deaths on the high-dose octreotide versus the lutetium arm. Hazard ratio of 0.4 with a p-value of 0.004. Although it's important to acknowledge this is an interim look at overall survival, where the threshold for significance is 0.000085. So not yet statistically significant. It needs to be confirmed on final analysis. Everolimus is a drug that's not always easy for patients to tolerate on a day-to-day basis. Most patients experience oral aphthous ulcers. Other side effects include rash, fatigue. We've mentioned diarrhea. There's increased risk of infections because it's an immunosuppressant drug. There's concern about peripheral edema. And there are also lung toxicities, including nonspecific dyspnea as well as pneumonitis, which is especially concerning in a patient with pre-existing COPD. So, when it comes to risks and day-to-day quality of life, I think you can make a very strong argument favoring peptide receptor radiotherapy, where the NETTER-1 study demonstrated a rather low rate of toxicity. There's a rate of clinically significant myelotoxicity that's less than 10%. There seems to be, from previous long-term follow-up, a rate of severe myelodysplastic syndrome occurring in roughly 1 to 2%. It's a very small fraction of patients. Otherwise, this is a drug that's given only 4 times over 8 months and tends to be exceptionally well tolerated. So I think in this case, even though everolimus is a legitimate option, I would choose lutetium dotatate. Now, we can speculate about hazard ratios between the various RADIANT trials and the NETTER-1 study, but I'm happy to say that there's finally a trial that's initiated enrollment that's actually comparing the two drugs, or a very similar peptide receptor radiotherapy drug, lutetium-177 adotriotide versus everolimus in patients with non-functional gastrointestinal neuroendocrine tumors. So exactly matching the patient profile that we have in that case. And hopefully in the coming years, we'll have some answers as to which drug is associated with an improved benefit versus risk ratio.
So just the COPD, I included it on purpose on the case because I've seen patients with COPD developing more. Actually, the 2 patients that I've seen that had severe pneumonitis, they had COPD. So I would like to ask you both, what's your experience about this?
I have very little experience on this particular subset of patients. It depends on what you understand by mild COPD. This is measured by functional respiratory tests, and I don't have the answer.
I've certainly seen lung toxicity. It's hard for me to say whether it's been increased in patients with underlying COPD, but I've had several patients with underlying lung disease develop severe pneumonia. So I think you have to be concerned about use of everolimus in several populations, including patients with pre-existing lung disease, also patients with uncontrolled diabetes, and patients who are at risk for infection.
Okay, thank you. We will now close the debate.